model, which is primarily focused on treating people with first episode psychosis, something that I feel very strongly and passionately about, and I hope that today is really informative for you. So kind of the goals of today really are to be able to help individuals who are not otherwise familiar learn to identify the signs and the symptoms of psychosis, understand the research behind this navigate model of care, as well as some of the outcomes that were demonstrated in the RAISE-ETP trial that we also then anticipate in our outpatient work that we do with Navigate, as well as learning about the interventions and the interdisciplinary team model that is used in the Navigate model of treatment, and then how to make referrals if you're local or living somewhere kind of in the Duluth area as well. All right, so let's start off with just a general conversation about what psychosis is. Generally speaking, psychosis is a condition of the mind that is described as involving a loss of contact with reality. There are many symptoms that fall under this umbrella term of psychosis, and you can see them grouped together in sort of three separate components. There are positive, negative, and then cognitive impairments that people typically see. Positive symptoms, I think, are often what people typically think of when they think of psychosis. So hallucinations, hearing voices, seeing things that other people cannot see. Delusions are those false beliefs, holding thought to be true that the evidence doesn't really support within kind of common reality. And then disorganized thinking or speech. Sometimes sentences themselves are very unclear. People may act in ways that don't make a lot of sense. Those are those positive symptoms. Positive in the sense that they're typically an experience above and beyond the normal experience. There's also these negative symptoms. So where positive is additional experiences, negative symptoms are when our common experiences are lacking in some way, or there's an absence of what we would otherwise expect to be present. So negative symptoms include things like impaired socializing skills, difficulty following through and completing daily activities, whether that's showering or maintaining hygiene, being able to check and go through the mail, being able to have the motivation or the energy to get up and go to work or to go to school. And also it can be characterized by this physical flattening of people's affect, where they're just not showing a lot of emotional expressiveness in their face. The third grouping of these symptoms of psychosis are cognitive impairments. Oftentimes people with psychosis describe having poor memory or difficulties concentrating, difficulties with attention. They may have impaired executive functioning, which is when it's kind of like when people are really trying to put all of the pieces together to get from A to B to C. It's a lot of problem solving. That can be quite difficult for people with psychosis. And so all of these different symptoms come up for individuals that are experiencing this umbrella of psychosis. You can see there's different colors on this slide. So those positive symptoms in blue, those are the symptoms that are really best addressed with antipsychotic medications. We know that somewhere between 70 to 90% of people with a first episode of psychosis are pretty receptive to medications for treating those hallucinations and delusion, some of the disorganization. The negative symptoms and those cognitive impairments aren't as adequately treated with medications, and that's where a lot of our psychosocial interventions through therapy, learning different coping skills, eliciting the support of family for encouragement is really more critical. So I think a really important thing to note is just that for any person that's experiencing psychosis, this can really create an incredible amount of distress to that individual and to their family. A lot of the experiences listed here are atypical. They're not common that somebody hears voices. We know that 3% of the population experiences psychosis at some point in their life. And that is much more common than other medical disorders or other kinds of psychiatric experiences. And at the same time, there's a majority of people that can't relate to these experiences. So it can be really alienating for people that have psychosis. So why does it matter that we provide really exceptional care early on in the course of somebody developing psychosis? One form of psychosis is schizophrenia. Schizophrenia affects 1% of the world population. This is a chronic medical illness that is primarily characterized by symptoms of psychosis. And as you can see on this slide, the prevalence rate of schizophrenia is much greater than many other physical health ailments that many of us have heard of. With insulin-dependent diabetes, 6 times as many people will be diagnosed with schizophrenia. 60 times as many people will be diagnosed with schizophrenia than muscular dystrophy. It's also really important to note that the World Health Organization has ranked schizophrenia as one of the top most debilitating illnesses in the world. They've talked about how schizophrenia really seems to be the 3rd most disabling condition. And that's related to a lot of functional impairments. Many people with schizophrenia have difficulties maintaining work or independent housing. Relationships can be impacted. And there's also a high mortality rate. As high as 10% of people with schizophrenia will die from suicide. And that's really significant because that's compared to 1% of the general population. So this really matters because there are many individuals across the world that are experiencing psychosis. There are many people experiencing schizophrenia specifically. And this is an illness that has an incredible impact on the individual lives of the person, on the lives of their families and friends that are watching the impact of this illness, and on society at large. So why navigate? Why this particular model of care? Well, as I mentioned, psychosis is relatively common, and navigate is one of the empirically based multidisciplinary or interdisciplinary approaches to treating first episode psychosis. So what that means is navigate aims to intervene quickly and early before many of these longer term negative impacts really take root and take hold. There was federal funding made available through the Cures Act, and because of that funding, there are 4 teams in the state of Minnesota that are currently providing this navigate model of care. I run one at Hennepin Healthcare, formerly HCMC, in the HOPE program. There are 2 navigate teams through mHealth out of the St. Louis Park Clinic location, and there's 1 team out of Duluth that provides service across some of the surrounding geographical area as well. So navigate, as I mentioned, it's really designed to be an early intervention treatment specifically focused on schizophrenia spectrum diagnoses. So for those that aren't very familiar with what that means, we're really focused on schizophreniform disorder, which is when somebody is experiencing symptoms of psychosis, but they've been present for less than 6 months. For people who have schizophrenia, which is when those same symptoms continue and persist beyond 6 months, and then a person can become diagnosed with schizophrenia. And also schizoaffective disorder, which is really a blend of both symptoms of psychosis and mood symptoms. This is not to be confused with bipolar disorder, even bipolar disorder with psychotic symptoms, where a person is only experiencing psychosis in either that manic or depressive state. Schizoaffective disorder occurs when somebody may experience mania and depression or just depressive episodes, and also has psychosis within and outside of those mood episodes. This work has really been validated to treat individuals that are between the ages of 15 and 40 years old. We know that schizophrenia, typically an onset is around the late adolescent, early adulthood period of time. And again, this is an early intervention program, so this is not to be used with a multi-episode or more chronic population of people who are experiencing psychosis. So the Navigate model is really built on a number of foundational components. There is a lot of emphasis on this stress vulnerability model to understand the development of symptoms. There are a lot of emphasis placed on recovery and resiliency. Principles of both illness management and psychiatric rehabilitation are very prominent in the Navigate model. And because of this being a first episode specific intervention, there's a lot of special considerations for what that population might uniquely be experiencing. So talking about the stress vulnerability model, when I'm meeting with clients and with their families, a huge question that comes up is, why did this happen? I think this stress vulnerability model really creates a nice understanding of, to the best of our knowledge, why illnesses like schizophrenia develop. It's also a really great way to look at, where do we go from here? Now that these symptoms have occurred, how do we actually go about treating those symptoms? So the stress vulnerability model is focused on two parts. There's a biological vulnerability, and that's where we talk about genetics, if there's a family history of psychotic illness, or we think a lot about just brain chemistry. How does that individual person's brain actually function in terms of their neurotransmitters that increase their likelihood of developing a psychotic illness? So the biological vulnerability is one part, and then stress is that other part. Really, how are people impacted by these external influences that create stress? And there's an interaction between those two that increase the likelihood that somebody would go on and develop psychosis. Now, there's a lot that we can do to treat that. For the biological vulnerability, when people minimize or eliminate their alcohol and drug abuse, or things that are otherwise affecting brain chemistry, that can help to mitigate the biological vulnerability. And medications certainly play a role in the brain and help to reduce not just symptoms, but also rates of relapses or rehospitalizations. On the side of stress, there's a lot that can be done to help bolster social supports that people have, teaching and practicing coping skills for managing stress, for learning how to manage different symptoms, as well as finding meaningful activities for them to spend their time doing, because for any of us, if we're doing things that are meaningful, it's going to help us feel less stress overall, and that helps people in their recovery. So to talk about some of the different driving principles or philosophies, this idea around resiliency and recovery is really embedded in all of the different aspects of Navigate. Essentially, we believe that people become resilient through experiencing difficult things, and that recovery is absolutely possible. So we talk a lot about how people are becoming stronger through the experiences that they're having and moving into this place of recovery for themselves. The philosophy of illness management really assumes that there are things we can do to reduce relapses and symptoms by taking antipsychotic medications, lowering alcohol and drug use, increasing social support, learning coping skills, things really tied to that stress vulnerability model. And psychiatric rehabilitation focuses on outcomes not just related to less hospitalization or fewer symptoms, but also, what does it look like in terms of people's work and school opportunities, in terms of the relationships that they have, the stuff of life that actually makes us all feel like what we're doing is worthwhile. And so all of that is really built into each component of that navigate model. Some of the special kind of considerations in first episode psychosis clients are their developmental stage. So as I mentioned, typical onset is adolescence, young adulthood. Well, this is the time when many people are still living with their families of origin. They are in the process of becoming more independent and separating away from their families. Relationships, particularly peer relationships, are really essential for this demographic of individuals across the board. People are starting to have more romantic relationships. They're starting to try and figure out what they're going to do with their lives. Are they going to go on in school? Are they going to look for work? Kind of what's that going to look like? Substance use rates are very high in this age, and individuals in their teens and early adulthood are also really sensitive to criticism. And there's also this perception of being invincible, that what they're experiencing probably isn't that serious, or even though their psychiatrist said that it's important to take these medications every day, it's probably not that important. These are really important things for us to know as providers offering care, because when I'm sitting across from a 17-year-old who really doesn't think the hospitalization that he went through was all that serious, that person's less motivated to do the work of learning about their symptoms, learning coping strategies, taking medications that might reduce the rates of hospitalization. And it isn't anything about their psychosis. That's because they're 17 or 18 or 23. So we need to understand that in order to really inform how we have conversations with people. I think the other special issue is just to not underestimate the presence of trauma in this population. So for many individuals, their first interaction with the mental health system might be when mom or dad or the school called 911 because they were behaving so strangely, and the police come, and the next thing they know, they're being brought into the hospital by ambulance against their will. That is a traumatizing experience. These symptoms of psychosis can also be incredibly traumatizing. Hearing voices, becoming very confused about reality versus what other people think is happening, all of that can also be really traumatizing. So we target that directly because we know that many people actually experience post-traumatic stress disorder reactions in relation to their psychosis, and that for people who do have these PTSD reactions, it tends to result in poor outcomes, decreases in functioning, and increased distress. So as much as we can target that trauma, the better able we are to provide that recovery. So I'm not going to spend a huge amount of time on kind of the empirical basis, but I do think it's important to highlight that this is something founded in research, that we know that what we're doing actually has the intended outcomes. So very quickly in 2009, the National Institute of Mental Health launched the RAISE initiative, so the recovery after an initial schizophrenic episode. 2 contracts were awarded. One was a program that is now on TrackUSA, and the other was the program that's now Navigate, the one that we're talking about today. With Navigate specifically, there were randomized control trials that compared people receiving Navigate to treatment as usual, and this was done in community mental health agencies around the United States. The goal was to make this something that could be given in your typical mental health agency, that you wouldn't need a lot of special opportunities to be able to provide this care. The goals were not just to reduce rates of hospitalization, although that was one of the outcome goals, but also looking at quality of life factors. So people having better relationships, people who are returning to or staying in school or work settings. For all of the programs providing Navigate in the studies, the clinicians were really carefully trained and monitored. A lot of outcome data was collected over the course of 2 years, and all participants evaluated did participate in at least 2 years. So what they found is that when they compared these two different interventions, the Navigate and the Treatment as Usual interventions, they found that people engaged in Navigate were more likely to stay in treatment. They had fewer symptoms, greater quality of life by their subjective report, as well as objectively looking at work and school and relationships. And so Navigate, we felt really strongly, accomplished those intended goals of what the program set out to do. So let's talk a bit about this model now. Kind of what does it actually look like? One of the key components to Navigate is that it is an interdisciplinary model. So as we talk about the various interventions, you'll see that there's a lot of specialized roles. But the key to Navigate working effectively is that all of those specialized roles share a common philosophy, work very collaboratively and closely together with one another, as well as with the client and the family, in order for this intervention to be effectively done. So there are some standard modules in the Navigate model: medication management, individual resiliency training, which is the individual therapy component, supported employment and education, and the family education program. Those are standard. In addition to that, my program, the HOPE program, and some others that are doing Navigate have also added in some additional components like case management and peer specialist services. All right, so medication management. Every Navigate team has a designated prescriber. And that person, their goal is to really provide intensive medical monitoring of antipsychotic medications. There's sort of this idea of we want to start low and go slow. We know that people with first episode psychosis tend to have, they're very sensitive to side effects from medications. And when people are experiencing side effects, they're less likely to continue to take medications. So prescribers working within the Navigate model are closely working with these individuals. They're seeing them every week for the first couple of weeks or first couple of months, and then at least every month after that. This is different from a lot of traditional psychiatry settings in that there's a lot more frequent visits. They use tools. There's a questionnaire that they use at every single visit that helps to monitor adherence, but also what's happening with the symptoms, what's happening with the side effects. That helps to make some informed joint decisions with the clients in terms of where to go next with medications. And a lot of education is put into the role that medications play in terms of relapse prevention. The kind of primary psychosocial therapy intervention is this individualized resiliency training. So every Navigate team as well has an IRT. Again, intensive service on the front end that can then lessen over time as the client has gotten through in a more acute period of time and they've gained a lot of education and a lot of coping skills. So the primary goals of IRT is really to help individuals identify their personal strengths, to learn and apply coping strategies that help them manage stress, that help them manage symptoms that may remain even with medications. And this is really done through providing education on psychosis, talking through these traumatic experiences that people have and helping them process that so that doesn't create an additional barrier. A lot of focus on developing a relapse prevention plan. So building awareness of what are an individual person's triggers and warning signs. What are the things that help them address those warning signs when they're coming up? How do we elicit the support of the people in their lives to also be paying attention for these things so that we can intervene quickly and early and potentially prevent another hospitalization or reduce the duration of a hospitalization than if people don't have any awareness of what to look out for. Just like all of the Navigate materials, there's a lot of discussion built in about a person's resiliency, their strengths, and there's a very thoughtful approach to identifying and developing goals. Goals are something that we in the Navigate model feel strongly should be completely client driven. So we never assign a goal to an individual. So when we know what's important to that person, we can then shift and mold the care to really help them toward that goal that they have. So a lot of times this population, these teenagers, these young adults, they have goals related to going to college or getting a job, getting their own apartment, getting their driver's license, getting a boyfriend or a girlfriend. Within that, we can certainly talk about how learning to manage stress, learning how to check out the facts of some delusional thoughts, facilitate doing all of these bigger life goals that they have. And that's really built into the work of IRT, but it's also something that we take on as the entire interdisciplinary team that I'll talk about when I talk about kind of how the team works together. A component of Navigate that's a bit unique and different, I think, than a lot of standard mental health care in the community is that embedded in the team is an education and employment specialist. Their job is really to focus on school and work or volunteering goals that a person has. And it differs in a lot of ways from some of these IPS or other vocational rehab services that exist in states. We don't exclude anyone from working with the C specialist. Everyone is welcome to start working with that person right away. The goal is that we know when people are able to see their life moving forward, and school and work, these are two huge areas of meaning for people, that when people can see that their lives are moving forward that way, it helps to create a sense of hope, a sense of confidence that they are going to be able to move toward recovery. And so this is really a critical part of Navigate. The C specialist sits down, they help a person develop what their goals are related to school and work. They provide assistance in getting where they need to be, whether that's in resume development or doing practice job interviews, helping provide and discuss with managers or schools about necessary accommodations to be successful in those settings. It really is something that happens outside of the traditional clinic setting because the C specialists, they're going onto campus with people to check out accommodation services, or they're going to walk around a mall to see what different retail stores are currently hiring. They're really out and about because that's where people are finding work in school. So that's another unique kind of aspect to the work that the C specialists do. And the fourth kind of primary component of Navigate is the family program. So we know that for individuals with a first episode of psychosis, the more that they have supports within their social system outside of a clinic, their family, their friends, kind of those natural supports, the more their natural supports understand what they're going through and how to help support them, the better people are able to move toward their recovery. So this family program provides a lot of education on psychosis and the treatment. It's helping to teach the supports about the coping skills that their loved one will be using to manage stress or other symptoms, teaching a lot of skills for effective communication. How do you problem solve? How do you have difficult conversations that require negotiation or compromise? How do you have fun together? How do you also reinforce positive things that can sometimes get lost when a family is under a lot of stress? And then also kind of within this, we talk a lot about the particular impact that an individual having psychosis has, there's a ripple effect that it then has on the family. So the goal is to help reduce that stress and burden on the family so they have more of what they need to be able to feed that support back into the client who has that first episode. Because we also know that these tend to be lifelong conditions, we want to make sure that we're helping shore up this support system for this lifetime of supporting and being there for their loved one with psychosis. Now, these interventions, they can be done with or without the client being present. We also have a lot of conversations with clients about their willingness for family involvement, what that would look like, what we would talk about or wouldn't talk about. For some individuals, they're completely open to family being involved and knowing about their own personal experiences, and we can have these incredibly fruitful conversations. When we're talking about education on psychosis, you know, their son or daughter can say, yeah, I heard voices and here's what they were saying, to really help the family understand their own experience. Sometimes people don't want their family to know those personal details, and we can provide very general, basic education on psychosis without getting into the specifics of their loved one. And other times people aren't open to any family involvement. It's certainly not something that we require for people to take part in, though what I will say, and this is true of all of the different components of Navigate, is through the work with anyone in the Navigate team, we are all constantly looking for opportunities to connect a goal that that client has with some aspect of the service within Navigate. So somebody who hasn't wanted their family involved, but continues to bring up in the IRT sessions that their parents are constantly on their back and they've been nagging them and they just don't get it, the IRT clinician is going to gently and consistently bring up how family education may actually really benefit that client by helping the family not nag, but encourage and better understand versus kind of being on their back all the time. And so in that way, the team really supports utilization of all of these different services, even when people might be hesitant at first. So a couple of the additional components that in the HOPE program we've added on and we've really found a lot of value in. That first one is case management. The real benefit of having a case manager on our team is they can identify any other kind of community resources that might be lacking. So we found a lot of people have struggles with insurance, or they might be homeless and needing help finding housing. They might have food insecurity. Our case manager can identify where the needs are and then also help people access what they're needing within what exists in the community. I really want to point out that at least within the HOPE program, our case manager position is a fully grant-funded position, so it doesn't conflict when people have a county case manager. And we have that happen all the time. People come to us and they've got case management services either because they are on commitment or because they've sought case management services on their own. And then the case manager on our team just works really collaboratively with that external case manager in order just to make sure that that client is getting everything that they need. The other service that we've added into the HOPE program are our peer support services. So we have both a peer and a family peer. So the peer is an individual who has lived with symptoms of psychosis. They have experiences with having been hospitalized, having taken antipsychotic medications, experiences of having returned to school or work after having to leave when they had an acute episode. How did they talk to friends about the onset of these symptoms or what was going on prior to going into the hospital? And so that peer, the role that they serve is really to be an embodiment of hope, to be an example of someone who is resilient, someone who is working and living toward their recovery. It's somebody to bounce ideas off of. What's worked for me? What might work for you? It's somebody to practice socializing with, to go out to the mall or an art museum, to do some volunteering together. I think a real asset of having peers on a team is that they're somebody who gets it in a way that others may not. They are somebody who is going to be validating and supportive. And because of that, there's less risk, I think, to clients as they're just kind of getting back into what their life is now, having developed psychosis. I think there's a lot of comfort in being able to talk to somebody who gets it and somebody who isn't going to be rejecting just because what they've gone through might be different from what a lot of other people go through. The other peer component that we have is a family peer. So this is somebody who is a parent or a family member of somebody with psychosis. And again, same kind of goal, that embodiment of hope and recovery, but being able to connect with families and talk parent to parent about what it is to have a son or a daughter who's developed this psychotic illness, to be able to really validate and normalize the ambiguous grief that comes with somebody developing psychosis, the ebbs and flows of feeling accepting and not accepting of their loved one's illness, and also to help people access resources and connect with other supports, such as through NAMI and some of the family-to-family peer support, or family-to-family groups that meet up. So all of these different elements, I think, in and of themselves are effective, but the beauty of the Navigate model is that they're really interwoven. So Navigate focuses very heavily on the importance of this being a team-based model. Every single week, the team of all of those different specialists that I talk about, they all sit down together at the same table and they make sure that everybody's on the same page in terms of the clients that are being served. This is really critical for care coordination. This is a great opportunity to pool what people know from their work with the client to develop broader, more in-depth understandings of an individual's experiences and their goals. And also, I think it is a great model of care because we can all be reinforcing the work of one another. That again, it's not just with the psychiatrist that somebody's going to bring up their hesitation to taking medications. That might come up in work. They might be talking to the C specialist about, these medications make me so tired in the morning that it's hard for me to get to work on time. It might not be something that they necessarily think to share with their psychiatrist. And so everybody being on a team can relate critical information that helps all of the team members provide the best care possible. All of the members are very aware of the roles that one another play so that we can both reinforce that and support one another in our work. And this is something that is really visible to clients and their families. So at the beginning of treatment, a client and the supports that they want involved in their care sit down with the entire Navigate team and talk about what their goals are. We do this treatment planning meeting. Everyone has an equal seat at the table. Everyone has the opportunity to hear what is most important to that client and then to come up with this plan that everybody can agree upon that's going to help the client be successful. And then we sit down again every 6 months after that first one for the duration of their involvement to check back in on the goals, to see, has anything changed? Do we need to update things? What has that progress looked like towards some of these goals? Are we facing barriers? Have you accomplished that we need to celebrate? In the HOPE program, we build on this model of being team-based by adding in a lot of kind of extra components. So we offer and attend these quarterly dinners The goal is that this is an opportunity for clients and families to come together, to start to build a sense of community, to share a meal, to share stories. Sometimes we have speakers. Sometimes it's just simply we're grilling out at the park. Come by for, a free meal and some conversation. Again, we really want to highlight how team and community is involved in helping people move forward. We've hosted some special events. We had a Vikings player come and talk about recovery. And then we really like to celebrate accomplishments. So this includes throughout the time that somebody's in our program. We celebrate achievements, whether it's graduating from college or getting a new job or getting a significant other. And then when people have completed the program and are graduating out, we celebrate that. We have a graduation party. We let our clients pick what special treat they want. That ranges anywhere from ice cream cake to coconut cream pie to guacamole. We give people a little gift as a reminder of their really hard work. And it's a chance to reflect back on everything that individual has done and how far they've come in their recovery, and just a chance to really celebrate that. So working at Hennepin Healthcare, I can talk kind of specifically about the program that I run. So for those that aren't familiar with Hennepin Healthcare, we are the safety net hospital for Hennepin County. It is our mission to provide exceptional care to all people without exception. So we think it is crucial we provide care to people regardless of their insurance status, regardless of what language they speak, regardless of any other kind of unique element to who they are, because we think all people are deserving of equal exceptional care. On our team specifically, we have two primary psychiatrists. We have one that focuses on our 18 and older clients and one that focuses on our 15 to 17-year-old clients. We also currently have two psychiatry residents that are doing some training in our program. We have one IRT clinician, we have one C specialist, a peer support, a family peer support specialist, and a case manager. And then I have a dual role of being both the program director and the family clinician, which is very typical for the Navigate model. Our clinic is located in the downtown campus on HCMC's campus, which is right across from the Vikings Stadium. But we also provide care out into the community. So we are more than happy to meet with people at home or school, coffee shops. Everyone on our team has the ability to go out and provide care in the community, with the exception of our psychiatry members, because they need to have the nursing staff there. But otherwise, we've been very flexible in meeting people where they're at. And the goal of that, and this is consistent with Navigate, is as much as we can, we want to reduce barriers that are getting in the way of people being able to access care. So if people aren't able to come in, we will go and meet them where they are. I also want to point out that just because we are part of Hennepin Healthcare, we are not restricted to only serving people within Hennepin County. We currently are treating people in Ramsey County, Dakota County, and if people live even farther out than that but are willing to come in, we're willing to work with them. We've had people commute from St. Cloud. We've had people commute from other parts of kind of outside of the metro area. So as you're thinking about people that you might be working with and who a good referral is, so the inclusionary criteria are that somebody needs to be within the ages of 15 and 40. That's where the model's really validated. We want to be intervening early again. So we want a person to have been experiencing symptoms of psychosis for less than 2 years and to have been on antipsychotic medications for less than 12 cumulative months. So in those 2 years, if somebody was on medications for 3 months and then off for a few months and then on again for a few months, as long as it's less than 12 cumulatively, those people are eligible for enrollment. This is a voluntary program, and so when people do the best, it's because they're coming in and they're interested and willing to engage in a program to work on goals that they have that are important to their life, that are important to their recovery, that they are willing to work with professionals in their accomplishment toward those goals. And I will also say, when people are somewhat ambivalent, they're not really sure if this is the right fit for them, I always encourage them to be referred, because we do a lot in terms of engagement, warm handoffs. We know that this can be a lot for somebody to consider becoming a part of. There's a lot of elements. I also recognize that just the development of psychosis is very stressful, and that can make it hard for people to access care. So while we don't require that people are ready to hit the ground running with therapy goals and those kinds of things right away, if there's an openness to having a conversation about it, that works really well for us. There are some exclusionary criteria. So we focus on schizophrenia spectrum disorders. And so when psychosis has other kinds of causes, whether it's a substance-induced episode or related to a depressive or manic episode, borderline personality disorder, autism, whenever it's something that isn't schizophrenia related, those would be better referred elsewhere. I will say it's not always clear. Many of these, as we talked about, some of the special considerations, many of these individuals are using substances. And it may not be that there's been a period of sobriety long enough to really say if it's a substance-induced psychosis or schizophrenia spectrum disorder and substance use comorbidly. When in doubt, I would say refer, and we err on the side of caution. If we can't tell, we will enroll individuals, and then if at some point it becomes clear that this was purely substance-induced, we help connect them to more appropriate services. But I'd rather have someone enrolled and err on the side of caution rather than not enroll that individual. The other exclusion is that when people have lower cognitive functioning with like a full scale IQ below 70, a lot of the material that we use for the Navigate model just isn't as accessible. And so those would also be individuals that would be best referred elsewhere. So if you're interested in referring someone to the HOPE program specifically, we try to make it pretty easy. You would just call our clinic phone number with your referral. For more information about what we do, we've also got a website that you can check out. And I've listed here the Navigate website as well. A benefit of this model being an NIMH funded research program initially and then expanded out is that it is all available to you. So if you go on to navigateconsultants.org, you can see the manuals that are used by all of the different disciplines on the team. You can also get some really nice research articles that show the outcomes of Navigate, as well as some other information about that model. So I encourage you all to go and check those things out. All right, so I think that brings us to our time for some questions that you all might be having. I think we've got a little less than 10 minutes for questions, so let me know.
Okay, well, thanks very much, Marielle. It's been really interesting and enlightening to listen to the presentation that you did today. We do have a couple of questions that have come in, and please, anybody else who wants to ask a question, please enter it into the question and answer box or the chat box. So the first question is there any correlation between psychosis and prior mild head injury or concussion?
Mm-hmm. Yeah, that's a good question. So some individuals that have had a head injury may experience some personality changes and perceptual changes that can seem psychotic. If it was really clearly associated with that head injury, then those would not be individuals that would benefit from the Navigate model of care. That would be more of kind of a psychosis believed to have a neurological or an organic basis. I think for the most part, psychosis that is a rarer cause of some of these symptoms of psychosis, although not an impossible cause.
Okay, the next question. Are the peer support services a paid service? If so, what is the reimbursement for both the peer and the family peer specialist and the peer specialist?
That is a really good question. So in the state of Minnesota, there are peer support services that are reimbursable in certain settings, like at a like I think intensive rehabilitation treatment settings or IRTS facilities. They are not reimbursable services in an outpatient clinic setting like the one that I operate in. So our peers, both the peer and the family peer, are grant funded positions. I know that there has been a huge national discussion about how to really create more opportunities for reimbursement for these services because there's such value in them. But at this time, it is not something that is reimbursable in just your outpatient setting.
Okay, next question. So when reviewing medications for your clients, do you consider dietary needs? For example, do you talk to your clients about the correlation with having a good diet to encourage medication metabolization?
Mm-hmm. Yes, so that's an excellent question. Some antipsychotic medications really need to be taken with food in order for them to be fully metabolized. So there's a lot of education that we do around that. We talk about health quite a lot. It's built into the work that the prescribers do, that's done in IRT, that's done in the family education program, because we know that these antipsychotic medications do have an impact on metabolism. They can result in some pretty significant weight gain and other physical health problems. And so we talk to people a lot about, if we can anticipate that you might experience some weight gain, what are the things that you can be doing to really pay attention to your food intake, to make sure that you're getting good exercise? We use a lot of additional services in the HOPE program specifically. So being a benefit of being part of Hennep and healthcare is there's lots of other professionals that we can utilize. We have had people connect with a nutritionist to better understand kind of what they can be eating, what's recommended. We also, as much as we can, get people connected with a primary care provider within our system so that we can do some really good care coordination around other kinds of health issues that might come up as well. But yeah, we do a lot of education on food and just physical health.
Okay, we've got a couple more questions here. Next one is, how does Navigate coordinate with other providers connected to these clients?
Mm-hmm. So we always encourage people to sign releases of information so that we can coordinate with other providers. There are certain things that are not built into Navigate. Like I mentioned, we don't have a nutritionist or a primary care physician on our team. And so instead, we tend to use a lot of staff messages or phone calls if they're external to our system. We do, at least in the HOPE program, we do have some individuals that came to us having worked with an external psychiatrist that they didn't want to switch. We don't require that people switch to our psychiatrist. We kind of help work through some of the pros and cons of why they might or might not switch. What we do ask is that people at least sign releases of information so that we can talk within each other, so that if we know there's a change to medications that they're receiving, or if they come to therapy and they're very sedated and unable to really participate fully, we want to be able to share that back with who the prescriber is or who some of those other important providers are that are working with the person.
Okay, another question. Given the individualized approach of the Navigate model, has there been any attempt to adapt this model culturally to Native people here in Minnesota or elsewhere?
That's a really good question. So, I think one of the benefits of it being individualized and done on an individual basis versus a group format is you can make some shifts and changes for increased cultural awareness. There's a lot in the training of Navigate where providers are taught to be very conscientious about using a person's language, understanding culturally what the perceptions of different experiences might be. And we don't want to pathologize something that isn't pathological. So when I'm talking with individuals, to give one example, I was working with a woman who was Native American, and some of the experiences that she had were very consistent with other people in her family, other people in her culture, and that were really comforting to her. I was explicit about not planning or intending to change any of those experiences, but rather addressing some of these really critical, detrimental voices that she was hearing, the ones that were getting in the way for her life. And so I think there's a flexibility that comes from targeting what is problematic to the individual as perceived by them, and not identifying every experience as something pathological.
Okay, one last question. Do you have any spiritual component to the program?
That's a really good question. So we do not have anyone specifically in the program to talk about spirituality. And the reason for that is that everybody's spirituality can be so different. However, we do really try to partner with the people in their lives that are important to their spirituality if those people are there, in the same way that we'd partner with other providers. So we always offer to have a religious leader or someone else that they think is part of that support system outside of our clinic. We always are offering to have them be a part of the conversation, and really recognizing that there is no one way for people to feel like they're getting the treatment and the care that they need, that spirituality can be a really big part of an individual's recovery. And we want to make sure we help foster that.
Okay, well, it's right at 1 o'clock. And so before we close off here, there was a question about, will the presentation be accessible through online? And it will. All of our webinars are recorded, and then they're placed on our website, past webinars. So this one should be available to be viewed early next week. Just a couple of other things. The PowerPoint from Marielle's presentation today will be sent as a attachment to the email that you'll receive with the link to the evaluation and post-test. And then next month, we're starting to use a new software to transmit our webinars called Zoom. WebEx is going away from the University of Minnesota, and most of us are happy about that because there have been problems, and I know some of you experienced them today, being able to hear it all or hear well. I think you'll find this new software, Zoom, a much better alternative. So when you go to register for the upcoming webinars, you'll notice that there's a little different format for registration, and that's because we are using Zoom. We have our next 4 webinars scheduled. 2 of them are already on our website, and you can register for those. The one next month is on e-cigarettes, and the one following that is on the research that was done by Wilder on homelessness in Minnesota. So with that, again, thank you very much, Marielle. Thank you all for being here and participating in today's webinar, and I hope to see you again next month. Signing off. Bye, Marielle.